Good afternoon, everyone. I'm Hassan. Today, me, Zul, and Dr. Zul will be presenting regarding AKI and RT, supervised by our specialist, Dr. Jason. Okay, we will start our presentation today. Our topic is AKI and RT, renal replacement therapy in critical care also lah. When and what and how to do it right lah. Okay. So the big questions: when do we initiate? What is the best modalities? What is the differences? How much therapy is enough? And also, can we improve the outcome? First, we must know the basics lah for the RRT. So the basics RRT is a simple diffusions. Diffusion is a movement of solids across the membranes lah, from higher concentration to a lower concentration. Then we have the ultrafiltration, which is a movement of solvents or fluids due to the pressure gradient. And also we have the convection, which is movement of the solvents lah through the with the fluid, such as these water streams. With movements, the water involve the movement of water, causing the rocks to be moving as well. So types of RT, there are few types of RT, CRRT, peritoneal dialysis, hybrid, and also HD, IHD lah. This is the IHD and a CRRT circuit lah. Different mechanism lah for both. And this is the hemodialysis filter lah. Okay. The hemodialysis also can be divided into slow continuous ultrafiltration, CVVH, CVVHD, CVVHDF. There are a few types lah for this. So the advantage of intermittent HD: less bleeding, lower cost, less interruptions, better for hyperkalemia. And the disadvantages is not suitable for intracranial hypertension, not suitable in hemodynamic instability, inadequate fluid control, not able to remove cytokines. The advantages for CRRT is better hemodynamic control, easy fluid balance control, continuous removal of toxin. The disadvantages is greater cost, risk of hypothermia due to the blood having outside of the body for a longer time, and prolonged anticoagulation, and also immobilization. So what is AKI? AKI equal to oliguria plus exothermia. But according to latest KDIGO, also it's an abrupt reduction in kidney function to a level insufficient to meet the needs of the patients. So AKI have been evolving the definition have been evolving lah. Previously, we used the rifle in 2004, then developed into Aki in 2007. Then the latest one is KDIGO in definition of acute kidney injury. It can be divided into 3 stages: stage 1, stage 2, and stage 3. Divided into a creatinine criteria and also urine output criteria. So for the creatinine criteria for stage 1 is creatinine 1.5 to 1.9 above the baseline, or creatinine increased by 0.3 milligram per deciliter. In the urine output criteria for stage 1 is less than 0.5 ml per kilo per hour for 6 to 12 hours lah. And the stage 2 is creatinine clearance, creatinine 2 to 2.9 times baseline, or urine output criteria of less than 0.5 ml per kilo per hour for more than 12 hours. In stage 3 is creatinine more than 3 times baseline, or creatinine more than 4 mg per deciliter, or initiation of dialysis with the urine output criteria of less than 0.3 ml per kilo per hour for more than 24 hours, or anuria more than 12 hours. So why is it important? Based on this, there is a study of 143 studies done with about 3.5 million patients globally. Among hospitalized patients, based on the KDIGO definition of AKI, 23% of these patients who are admitted to the hospital are having AKI, which translates to about 1 in 5 patients. So this one lah. So how about in ICU care? There are higher burden in ICU care, which according to these studies, shows that around 97 studies shows that in ICU, 57% of patients develop AKI in the first week of admission. So the main culprit of AKI is sepsis lah, okay? Followed by the other things, major surgery, hypovolemia, drug-related, cardiogenic shock, hepatorenal syndrome, obstruction UD tract lah. And this is the AKI associated mortality rate lah, okay? According to the KDIGO large meta-analysis in KDIGO studies, AKI associated mortality is around 23%. The higher the staging, for example, those requiring dialysis, the chance the AKI mortality rate is around 50% lah, 49.4%, almost half of the patients associated with the mortality. So when is the best time to initiate? The intensivist says early, meanwhile the nephrologist says when indicated lah. So what is the indication? Because we all know, we previously learned there's some mnemonic for this lah, AEIOU, in acute management of life-threatening complication of AKI, such as A is acidosis, metabolic acidosis of pH less than 7.1. E is electrolytes, hyperkalemia, or rapidly rising potassium. I is ingestion, certain alcohol or drug intoxications. O is fluid overload, refractory fluid overload, and U is uremia. Is it in example is pericarditis, neuropathy, decline in mental status. There are new extra renal indications that are done lah, they are made lah, such as severe sepsis and multi-organ dysfunction syndrome, optimization for surgery, and poor disease recovery with debatable high serum urea. But all these indications still a matter of debate lah. So it's not is patient to patient basis lah. So according to this paper is based in Australia 2017, an isolated elevation of in blood urea level is not uremia and not an indication for RRT in the ICU. The current trend in initiating RRT in ICU is often based on isolated blood urea levels without clear guidelines demonstrating upper limit of the treatment for the treatment. Reasonable to conclude that blood urea level less than 40 is not an indication for RT, especially in the absence of supporting evidence of kidney impairment lah. So this is the landmark trials in RRT initiation in critically ill patients. There are few trials done, initiated by Bomal trial in 2002, saying that no difference in mortality between the early versus late RRT. Then in 2013, there is early RRT had no improvement in mortality and delayed improvement in kidney function. In 2016, there are two trials done, which is the Elaine and Akiki, which I will explain later. And then there is 2018, there is ideal ICU trial, which no difference in the primary outcome between early versus late RRT groups. And the latest is start AKI in 2020, which show also no difference in outcomes between early versus late RRT groups. So these are the two trials that I want to inform, I want to explain further. In Elaine trial in 2016, it was published, it was based in Germany. It's a prospective randomized single center, involves AKI stage 2, Mostly is surgical patient 80% and medical patient 20%, and most all of them is CVV HDF. 90-day mortality rate shows that early is 39.3%, while delayed is 54.7%. So there is some significance in this lah. However, in another studies which was done in Akiki, is a multi-center randomized prospective trial. It involves in AKI stage 3, involving 620 patients. Mostly are medicals, 80%, and they are mixed intermittent HD and CRRT, which shows 60-day mortality is about the same, 48.5% early, 49.7% delayed lah. So these are the comparison of the randomized control trial that was done lah, which shows mostly is no difference in the mortality except the Elaine. However, the Elaine is the early time frame is around 8 hours lah. It's one of the most earliest lah. So in conclusion, this meta-analysis shows analyzed 23 studies, including 5 randomized control trials, which shows Akiki is more medical patients compared to Elaine is more surgical patients. And this shows that a significant survival benefit in the observational and cohort study. The published says that it did not improve survival or reductions in ICU or hospital stay lah. So what does the KDIGO 2012 says? Initiate RRT emergently when life-threatening changes in fluid, electrolyte, and acid-base balance exist, or consider the broader clinical context in the presence of conditions that can be modified with RRT and trends of the laboratory tests rather than a single blood urea nitrogen and creatinine threshold alone when making decisions to start RRT. So which mode are the best? It's like comparing the best with the best lah, such as Lionel Messi and Cristiano Ronaldo lah. Those tests are around the same lah, okay, which are shown they are the best in the respective field lah, okay. Meanwhile, this study shows is a hemodiaph study in French. It involves 360 patients with AKI and multi-organ dysfunction. Both are categorized into giving IHD and also CVV-HDF lah. And the endpoint is 60 days of mortality. Based on this graph chart, so basically the 60 days endpoint of survival rate is around the same, which is 32% for IHD, and CVV-HDF is 33%, which shows similar endpoint lah after 6 days of studies. And also this is another studies, convene trial single center. The effect of continuous versus intermittent renal replacement therapy on the outcome of critically ill patients with acute renal failure, the prospective randomized control trials. Survival rates at 14 days after RRT is IHD is 39.5% versus 43.9% in CVVH. However, in 30 days after the cessation of the dialysis, there is no statistically significant differences in the survival after 30 days. How about a hybrid therapy? Is that the answer? So, according to, there are 3 studies that shows in Baldwin et al. 2007, small study shows higher acidosis and lower BP, and also the VA NIH ATN trial, similar outcomes as compared to CRRT and IRT. And also in EDD versus CRRT for acute kidney injury, so also shows similar outcomes of CRRT. So basically, it only SLED is actually efficient in solid removal, low impact on hemodynamics, and low anticoagulant coagulant needs and minimal interference with the patient mobility. The category recommendations use continuous and intermittent RRT as complementary therapies in AKI patients. They suggest also using CRRT rather than standard intermittent RRT for hemodynamically unstable patients. They also suggest using CRRT rather than intermittent RRT for AKI patients with acute brain injury and other causes of increased intracranial pressure or generalized brain edema. So how much therapy is enough? What is the optimal therapy? So according to the New England Journal of Medicine latest, intensity of renal support in critically ill patients with acute kidney injury. Intensive renal support in critically ill patients with AKI did not decrease mortality, did not improve recovery of kidney function, or reduce the rate of non-renal organ failure as compared with less intensive therapy involving a defined dose of intermittent hemodialysis 3 times per week and continuous RRT. So this is the VA-NIH acute renal failure trial network ATN studies, which consists of 1,124 patients involving 27 sites and expanding to 3 years. The intensive phase involving a patient around 560, IHD of 6 times a week of 1.2 kTV per session. And the less intensive phase is the IHD 3 times per week with kTV of 1.2 per session lah. And in the unstable hemodynamics, they do a CVVHD at 35 ml per kilo per hour, or SLAD or EDD 6 times per week, or CVVHDF 20 ml per kilo per hour and SLAD 3 times per week in less intensive. So in critically ill patients with acute kidney injury, treatment with higher intensity, continuous renal replacement therapy did not reduce mortality at 19 days. This is also another trial, renal trial involving 1,500 patients, expanding to 3 years. The intensive patient CRT at 40 mils per kilo per hour, while the conventional at 25 mil per kilo per hour. And then also another trial, VA-NIH ARF trial network study, around also 1,500 patients, 20 versus 35 lah. Another one is 25 versus 40. No benefit and outcomes by increase in intensity of RRT dose. So the important thing is to not stop questioning. Priority has its own reason for existing lah. And then lastly is recent multi-center RCT have failed to confirm earlier trials suggesting benefit of higher CRRT dose in critically ill. Several differences exist among the various CRT dose/outcome trials, effluent dose, convective contribution and dilution mode, and timing of initiation. A one-size-fits-all approach makes it very difficult to establish a standard CRT modality and dose in an individual patient. Maybe it's time to say goodbye to any more CRT, high dose versus low dose, CRT versus IHD trials, because hundreds of studies including multi-center RCTs, meta-analysis have not shown any clear benefit over one to the other. And the choice of RT in critically ill is best left to the clinicians handling these patients, depending on the condition of the patients, infrastructure, expertise, and funds available. Thank you. Now we'll pass to Dr. Jason to continue on a bit more around case studies.
Hi guys. Before that, any question? I think I just want to summarize the presentation. Actually, unfortunately, this computer has no camera. I don't know why. Zulkifli, you're too poor to buy a camera, is it? Anyhow, to summarize the presentation, basically when we talk about CRT, IHD, and also hybrid therapy per se, okay, to choose what kind of modality, it's entirely based on the clinician, and of course, not just the clinician involved, the person who are seeing the patient also have to discuss with the nephrologist as well as the intensivist, okay? And not just that, it also depends on your center. For practical purpose, you have to see what is available. Okay, sometimes you have the machine, like you have the CRT machine, but you don't have the consumable. So that makes it impossible for you to prescribe CVVHD for a critically ill patient. Okay, so there are various trials. I think I don't know why there's so many trials, even though the landmark actually was Elaine and Akiki trial, which produced two contrasting results. And if you read further, actually, like Hassan said, Elaine trial involves mainly by the surgical center lah. And most of these trials are conducted by intensivists, okay, in their ICU. And yeah, so very contrasting result, but subsequent trials and like your ideal ICU, which is in 2018, and also your START AKI trial, more or less end the debate whether early versus late there's any benefit or not. Okay, so 90 days mortality, it's the primary outcome. They look at the mortality after 90 days. There are no benefit. In fact, there are higher adverse events such as hypotension, and also electrolyte imbalance such as hypophosphatemia in a patient who started too early. Okay, even for the intensive therapy, when you refer the nephrologist on call, let's say Dr. Wong is on call, and you ask Dr. Wong, boss, can I dialyze this patient 6 hours? Then you know what kind of answer Dr. Wong will give. Can you show me the paper that to say to dialyze the patient 6 hours has any benefit? In fact, no, because we know dialysis is a procedure. Okay, it's a treatment that you're giving, and whatever treatment that you're giving, there's also complication. You have to understand it's never a safe treatment if you don't know how to prescribe lah. Okay, it's like giving tazocin 6 gram QID like that. Okay, so I think it's quite clear. The case that I'm going to present, actually, it's just a recent case that I've seen during my on-call. So I actually entitled this, is it safe to prescribe traditional medication? Okay, let's look into the case and we walk through together. Okay, what's wrong with this slide? Okay, we have this 50-year-old lady. Hold on now. Nulliparous. She has underlying a few comorbids, hypertension. She's morbidly obese. BMI is 45, and her weight is 97 kilo, if I can remember correctly, and her height is only 151 cm. She also was recently diagnosed and admitted into our medical ward in January and also February for de novo heart failure. She has type 2 diabetes mellitus and also major depressive disorder. So when, I mentioned this, she was just recently discharged on the 27th of February to 2nd of March for decompensated heart failure and was advised to restrict her fluid 500 cc per day. Okay, and then these are the medication. I would say the person who did the discharge summary did a very good job because I can highlight which are the old medication and which are the new medication that was introduced. So you can see here the Lasix. Initially, she was prescribed with only 40 mg PRN basis. When you see your leg a bit swollen, your weight is increasing, you take some Lasix. And then it was prescribed into a regular dose of daily dose 40 mg. Perindopril is an old medication, 8 mg OD. And then metformin was increased from 500 mg BD into 1 gram BD. Atorvastatin is the old medication, 40 mg on night, and bisoprolol. She was added on to antihypertensive bisoprolol, 5 mg OD, and also amlodipine 10 mg OD. Okay, and yeah, I presume the BP was sky high when she was admitted in February. So what she came in with, you can see the plugging, it's a bit messy. So she came on the 5th of March at around 4 o'clock, 4 in the evening, complaint of dizziness, increase in purple attack, and has very poor appetite since discharge. She appears drowsy, BP is low, 94/42. Pulse rate is not tachycardic, 62. Bear in mind that the patient was discharged with bisoprolol. So that might not correlate clinically, okay? She's tachypneic, 36 per minute, 36 breath per minute, and SpO2 is 92% on room A. But she's afebrile when systemic examination is unremarkable. So the ED team actually did a DXT stat because she had a presyncopal attack. And the DXT stat is 2.8 millimole per liter, which is hypoglycemia lah, okay? And then they took a bedside ABG. Look at this ABG. When you see this, you will like jump from your bed and immediately attend the patient in ED lah. Obviously, this yellow shade will convert into red color after a while lah, when you see this ABG. So pH is 6.9, PCO2 is 33. Sorry, the ABG is not taken on high flow mass. It's a typo, sorry. It's on room A. PO2 is 63, bicarb is 6.9, base excess of -25. SpO2 is only 83. And you can see she has very profound hyperlactemia, lactate of more than 20. Bedside ketone is 33. Then let's look at the blood works, the immediate one, although it takes about 30 minutes to 40 minutes. But somehow when I received the referral, everything is lay on the table for me already lah. Okay, so she was admitted in February, right? End of February. Actually, she has a normal RP, creatinine of 70. And when she was admitted, the creatinine is 1,000, urea of 35 from 3.2. She has hyperkalemia, 3.4 to 6.5. And if you look at this, obviously it's a high anion gap metabolic acidosis. And then everyone will attribute it's because of your lactic acidosis. So what is the likely diagnosis here? Let's give you a few options. I know everyone is shy, but you can type your answer in the chat group. I just give about 15 seconds. What is the likely diagnosis? Euglycemic ketoacidosis, eternal poisoning, metformin-associated lactic acidosis, or DKA. So far, I see one answer. Wah, Amkian very malas lah. Hey, no one want to answer. Only two fellas. Three. Oh, everyone knows already. So everyone knows the answer. One more lah. I think I got 51 participants, but I only see less than 10 answers. Yeah, no, don't know. Not yet. Okay lah, 15 seconds is up. So I think most of you got it correct. I will explain why it's the answer is, yeah, metformin-associated lactic acidosis. In the past, it's called metformin-induced lactic acidosis, but when they look back, like, actually metformin, it has no direct correlation of this lactic acidosis. If you ask me the pathophysiology, forget it, because it's very complicated. When I tried to read it, why metformin causes lactic acidosis, I couldn't find. I mean, I don't understand. It's not, I don't want to explain further. It's more like I cannot be explaining when I don't understand the pathophysiology. So why not euglycemic ketoacidosis? Okay, number one, usually this condition is associated more in patients with SGLT2 inhibitors, your dapagliflozin, EMPA, and generally patient doesn't come with hypoglycemia, okay? Eternal poisoning. From the history, you couldn't get any, what do you call this? From the history, there's no evidence to suggest this, although she has major depressive disorder. It's a possibility, but it's not the likely diagnosis. Why not DKA? DKA, usually your glucose will be high, your serum glucose, your capillary sugar will be sky high. Okay, so the most likely diagnosis is metformin lactic acidosis. So what is a risk factor? I mean, all the question here is all below her risk factor except, okay, again, I need you guys to participate. Just type in the chat group. This one, the two presenters, Zul and Hassan, also don't know. Hey, actually, they know lah. Yeah, they look at the answer already. Oh, it's there. Gee. Oh, this is a slide share, is it? Presenter view lah. Sorry lah. I presenter view first. Okay lah. Most of you know the answer already. Unacceptable. Okay lah. Obesity. Okay. So we know this patient has heart failure. We know this patient was advised to restrict her fluid 500 cc. In fact, when we asked furthermore, because she was told to restrict, like, hey, you datang balik-balik, jantung dongkak lah, you kena control kamu punya minuman. So the patient actually just drink about 50 to 100 cc per day, which is, that's like less than half a glass. It's like, even for normal physiology, you cannot sustain your volume lah, okay? And yeah, so studies have shown the metformin-associated lactic acidosis correlates with the dosage as well. So obesity is not the risk factor here. Okay. So what happened? The progress here, what happened was in ETD, she was given about 2.5 liters steroidfundin and together with normal saline, even over 4 hours, okay? But she did not respond hemodynamically. So she was started on NORAD, inotropic support, and put on IVI actrapid. In a way, when we received the referral, it was a referral for euglycemic ketoacidosis, and she was covered for amyloidosis as well. And the urine output for the past 4 hours, despite 2.5 liter of fluids pumped in, it's only 50 cc for the past four hours. That translates less than 0.5 cc per kg per hour. And bedside IVC scan is 2.1 cm, not collapsible. So you know this patient is not doing good. And looking at this x-ray, how many of you will pump more fluids? Isn't it? And it's not easy. And when you look at the ABG, after given fluid results 4 hours later, did you see any improvement in the arterial blood gas? Actually, there's none, no improvement at all. pH is 6.9, PCO2 is 44, PO2 is 126. At this hour, patient already on high flow mass. Bicarb is 8.8, base excess of -23, lactate is still 20. And obviously this patient is obese and it's not easy to assess clinically. When you look at this lower limb, a lot of people will say, hey, she's still edematous lah. Hey, she's still dry lah. Maybe 50-50, so we don't know. So the best way to assess is to do IVC scan, but even for bedside IVC scan, it's operator dependent. In fact, there's no guideline to say how much of fluid is safe to give. But in your NICE guideline of fluid resuscitation, you should challenge a patient that you suspect under volume 500 cc of crystalloid within 15 minutes and see how's the response. But if you give more than 2 liter, you should seek expert help already. Okay, so I'm obviously not the expert here. It's a intensivist lah. Okay, so what is the first thing you do? Not first thing in the morning like this guy say, this is a emergent and emergency case lah. Okay, so what is the first thing? So there are a few options. Again, I want you to type your answer in the chat. This time no more cheating already. So do you give activated charcoal? Or do you give another 500 cc of fluid over 15 minutes? Do you consult nephrologist or ICU for hemodialysis? Or do you want to use isotonic bicarb? You know, just type your answer. I give 15 seconds. Okay, I see a lot of answers. Very good. Okay, I think most of you answered correctly. So this patient when you suspect metformin-associated lactic acidosis, you need to do a hemodialysis therapy. In fact, it's in your X-strip recommendation, which is your extracorporeal treatment for poisoning workforce. Okay, we cannot stop over this slide. Oops. So what's the progress of this patient? So he was admitted to ICU on the 6th of March at 1 a.m. after about 8 hours in ETD. I'm quite surprised because they didn't actually wait for the PCR result to come back. Actually, I just tell them I suspect this metformin-associated lactic acidosis, and they immediately take the patient and comments on CVV HD at 1:30 a.m. Initially with nil UF, because again, we don't know whether the patient is dry, whether it's hypervolemia, whether the patient is euvolemia, we don't know. The volume status is very tricky in this patient. Unfortunately, she was intubated at the next morning on the 6th of March. And then the ICU team actually suspect the patient is actually was tipped over the hypervolemic side, and which one of the complication is ARDS. Okay, this is her picture. Looking at the X-ray, the suspicion is confirmed. And then these are basically this is the progress over the past how many days? 4 days. So we can see after comments on CVV HD, we also need to know what is our primary endpoint. When do we have to discontinue giving RRT in this patient? Okay, so when we look at the first blood on the 5th of March, you can see it has a very profound AKI, very profound metabolic acidosis, hyperlactemia, and without the CVV HD, actually it did not improve at all, despite despite some will give sodium bicarb. Okay, it doesn't work. Okay, so after about 6 hours of commencing CVV HD, there is some improvement in terms of your blood gases. The pH actually went up to 7.09, and the bicarb actually went up to 18, base excess of -12, and lactate actually came down. But you can see she is very severely hypoxemic because of the ARDS. Okay, you can see the CO2 retention, the PaO2 is low. So that's when the intensivist decided to commence on UF about 200 mils per hour. So CRT is actually continuous. It just continue extract. 200 mils per hour is actually quite a lot, if you ask me. But look at from the blood parameters, you can see a marked improvement. On the 8th of March, the AKI actually, not to say resolved, it improved to a level that is acceptable. Urea of 6.4, potassium of 4.2, and pH of 7.34. The bicarb of 22, base excess of -3, and lactate went down to 1.5. So what is the endpoint of your RRT here? When do you want to stop? Actually, there is also a recommendation by the X-strip. The recommendation, you usually stop here. Why stop here? The intensivist actually stopped the CRT on the 7th of March in the morning itself after 56 hours of CRT, if I'm not mistaken. So the recommendation that was provided by the X-strip, I did not include in my slides because it's kind of last minute. Actually, the pH should be less than, more than 7.3, with a lactate less than 3, bicarb more than 22. So maybe this pH, I don't know what happened. Maybe there's another ABG when the intensity to stop it. Okay. So in conclusion, why did I say metformin is a traditional medicine? It's not actually, but you should know the history of metformin. The predecessor for metformin is fenformin, which has been shown to have a very profound incidence of lactic acidosis. And actually metformin was extracted by, if you remember the first slide, I show a picture of a plant. It's a Galaga officinalis. Okay, and this plant is used in European way back in the 18th century as a traditional medicine, and then they found out, hey, actually this plant actually can lower your blood glucose, and they actually extract a component of it and make into metformin. Okay, so is it safe in to prescribe? It's a question that we always have to look into ourselves and see what kind of patient that we see. Okay, so the last question, is this the last question? Maybe. So the parameters that indicates worse prognosis in metabolic associated lactic acidosis are, I mean, except which one? I give you some time to type your answer in the chat group again. Which one? Which one? I think during my presentation, I gave some hint already. I think Tan Junyan and Ng Kian only. Oh, okay lah. Okay, this is an easy question lah. Obviously, the answer is elevated TDM metformin. It's like your PCM poisoning as well. It doesn't correlate with the severity. You look at your coac instead of your level of your metformin, because if you pass a certain time of presentation, your TDM might not be accurate. Okay. And why your computer very. Okay, so what is the mortality rate for Mala? Who wants to answer this? Anyone can answer actually. Last question, I promise. This is not 1, 2, 3, 4 already. A, B, C, D already. Pay attention to the question. C. Anyone else? B. It's more or less the same people answering, so I just give the answer lah. This one maybe not many of you will know. Actually, yeah, oops. Yeah, so the mortality rate for Mala, it's rare complication, but it's actually very high, 48%, 47%, which almost up to 50%. Okay, so when we look into prescribing metformin, it's one of the best medication that ever produced for your oral glycemic agent, but it doesn't mean it's risk-free. Okay, so we have to look into our patient sometimes and communicate with our patient. I think what we can do better is sometimes we have to include a sick day rule. When the patient is not well, they should omit certain medication. Okay, this could help have prevented this kind of devastating complication. So my last slide, I just want to show some advertisement. So last year, actually, there's like top 10 stories that was in nephrology faculty, which you can see here. One of it is your KDIGO update. And then, of course, number 6, I think you read this in newspaper itself, successful pig transplanted into human. Not very halal, the story. But what I want to highlight is your number 10, Akiki 2. This, if you remember correctly, Hassan presented on the Akiki trial. And the same author, this bunch of French intensivists, they actually, the authors actually flipped, because they know start Akiki all throughout the years, the trial has shown that early versus late, it's kind of pointless to do the study. So they did this study. It's like a bit more extreme, I would say. It's like nothing else to study already. So they actually did a study for those patient late initiation for RRT versus even later. When patient indicated for HD RRT in your critically ill patient, and then they waited for another 72 hours. So obviously there is such thing as too late in HD and AKI. Patient die, okay? if you wait. I mean, if you wait too long, okay. So yeah, these are my references, and thank you. Any question? One. Okay, to address that question, let me see whether my bosses are here and I can direct to them. Nana, can okay. So only one question now. No more question already. So here there's a question. When should we refer nephro to initiate kidney replacement therapy for a critically ill patient? So not much of difference. Is there a preferred urea creatinine cutoff? You know, when you refer nephro, or yeah, actually when there's a stone cold indication, I think we all know what is the clear indication for HD lah, kan? Mainly oliguria, anuric AKI. You know, you don't wait until the kidney fail, but you want to support them. So you generally you intend to convey your message to the nephrologist that this patient is ill, okay? And number one, you have to say whether it's AKI or CKD first lah, okay? If you don't know, just treat as AKI first lah. I mean, there are some clues to say the patient has underlying CKD as well. So, so for AKI patient, you need to convey your message to the person that you're referring, and the patient is ill. This is the creatinine. It's not great to say a certain cutoff value of a number. You know, like I just mentioned during rounds this morning, I told my team, every number has a story behind it, why, and why. So when you have a critically ill patient and you convey the message, hey, the kidney is not doing great, creatinine is shooting up from 130, now it's already doubling up to almost 300. And then the urine output is reducing, and you can calculate, though, yeah, and the ABG shows a very severe metabolic acidosis despite adequate fluid resource. You know? So there are, in your KDIGO guideline to manage AKI, I know the main cornerstone is still the fluid, and a lot of studies have shown crystalloids versus colloids. There's no difference. In fact, colloids has more severe, I mean, more adverse event. And also there's one of the recommendations saying Lasix is not recommended except for hypervolemic patient, heart failure patient, okay, or for whatever reason, the patient is hypervolemic, then you can use Lasix. And yeah, I've seen even intensivists, they like to use Lasix even if the patient is oliguric. There are no clear recommendation on that. In fact, it's not recommended at all. And it's a strong recommendation. The graded recommendation is actually 1A, I think, 1A or 1B lah. Okay, so yeah, to answer that question, unfortunately, I cannot give a proper value for you, but if you really want to say urea more than 30, creatinine like more than 1,000, I mean, I think that's too late already lah. So for AKI, there's no clear cutoff point, okay? You have to convey, the mainstay is you have to convey your message, the patient is ill, you need to support the kidney. So how you want to do that? You have to have a few basic and a few fundamentals lah. Okay. Does that answer your question? Any more question? No more question. Yeah. With that, thanks everyone for spending time to listen to me having a monologue here. Thanks.
Okay, thank you very much, Dr. Jason, Fazul, and Hassan for the presentation, and for also taking us through the case of autoimmune associated lactic acidosis. Okay,